Hello everybody and welcome to the Hughes Clues Respiratory Pearls. This is a recording that kind of has a mishmash of different topics, but they're very important for exam 1. And when we talk about the first respiratory pearl, we're talking about how does ventilator management of the COPD patient, in other words, a patient who's either has emphysema or chronic bronchitis or asthma. Dr. Reed usually refers to them as just a generic COPD patient. Well, how does that COPD patient's ventilator management differ from the management of a normal or a patient who does not have COPD patient? So to identify how you would manage a COPD patient on the ventilator, we've got to first consider what would the normal COPD patient who's not ill, in other words, somebody that's just walking around, what would their ABG look like? And in a very stable patient, the COPD patient would have a pH of 7.38, bicarbonate of 34, CO2 of 55, and PaO2 73 and 90%. So let's look at that on our little grid. And we talk about the pH of 7.38, and when we're looking at ABGs, we see, okay, well, the 7.38 pH is normal, and that's what you would expect in a patient who is not ill. And then when we see that there is something out of whack, such as the elevated CO2, we know, okay, well, this is not a just a plain normal ABG, this is a compensated ABG. So we see that this is elevated, the CO2 is elevated, and with an elevated CO2, that pH should be low. It should be in the acidotic stage, but it's not. We know that it is a compensated acidosis, and the reason why it is compensated, that any long-term COPD patient is going to have compensation on a chronic basis. In other words, the kidneys are going to chronically either make more bicarbonate or hold on to bicarbonate. And it is this compensation mechanism, because it's a chronic stable patient, that has allowed the pH to stay in the normal range, despite the fact that on an everyday basis, COPD patient will have an elevated CO2. So that's probably the first thing you need to remember, is that any patient with COPD, whether it's asthma, emphysema, or chronic bronchitis, they're going to retain CO2. That is the pathophysiology of their illness. If you don't remember that, then email me, because I can guarantee it somebody's going to have it on either ATI, NCLEX, and of course in critical care. So we have this patient who is chronically compensating for this chronically elevated CO2. And so your COPD patient whose pH is in the normal range, even if the CO2 was 60 or 65, as long as they're kind of hanging out in this part of the triangle, then you have to consider that that patient is likely doing okay. How do you know that they're feel more confident that they're doing okay? Well, then you look at the oxygenation status of the patient. And we see that the oxygenation status, I think I have 63 on the triangle, but it's 73 in here, so I'll change that before you print. But we see that the oxygenation status is lower than normal, and even if it was 63 or 73, it's still considered to be, per Dr. Reed, in the doing okay range, and again, as long as the oxygen saturation is 90 or above. So I'm going to tell you what's very annoying for students, and that's, here's the rule for the ABGs and for patients, but now this is the rule exception, that when you have a patient that has a history of COPD, and you see that the bicarbonate the CO2 is elevated, as long as the pH is in the normal boundaries, is in the normal range, and on this side of the triangle, then your patient's doing okay, as long as the O2 sat is acceptable also. So this COPD patient, if they were on a ventilator, then that's pretty much where the goal is. The physician would not, because that's the second question, would you expect the pulmonologist to manage the ventilator to achieve a normal ABG? In other words, would the physician go, hey, that CO2 is high, we can't wean this patient off the ventilator? And the answer to that is no. As long as the pH is okay and the patient appears to be oxygenated, then this patient will likely be weaned off the ventilator, because these are considered to be essentially okay ABGs, and probably the patient can be weaned. Do patients with COPD take longer to wean? Sure they do, because they're pretty fragile. But for the most part, the pulmonologist is not going to try and make this patient have a normal CO2 before they wean them off the ventilator, because it's not going to happen when they're chronic COPDers. Hopefully that makes sense to you. Email me if it doesn't. Let's talk about some other pearls. The endotracheal tube with its balloon inflated allows the ventilator to push air into the patient's lung under pressure. And because the endotracheal balloon is inflated, air cannot escape around the tube. In other words, with this balloon in place, the whole purpose of it is to ensure that when air is going in through the ventilator and into the endotracheal tube, it goes down into the lungs. If this balloon was completely deflated, well, the air would follow the path of least resistance, and out, 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 out it goes. So again, we're talking about compliance. If you're a young person, the amount of air that's getting pushed in is going to be easy. That wouldn't take a lot of force from the ventilator to get air in, as opposed to an older patient or a patient with lung disease, it's going to take more. So we've talked about the fact that when the patients are first placed on the ventilator, the respiratory therapist assesses how much force it normally takes for this air to get pushed in, for the ventilator to do its job. And so once that assessment is done, then the respiratory therapist will set an alarm limit on the ventilator. And if you are the nurse that is taking care of the patient and the ventilator high pressure alarm's going off, yes, there is a respiratory therapist to assist you, but they may not be in the room at the moment the alarm goes off, and you, the astute nurse, should be noticing that the high pressure alarm's going off. So what does that mean, and what should you do as far as the assessment goes? So what that means is that as the ventilator was pushing in air, there was some form of resistance against the air flowing into the lungs. And that resistance to the air flowing in can take on or be caused by several different reasons. So the first reason is what we've already talked about in the hypoxemic respiratory failure, and that's that the lungs are becoming more stiff. So if this is a patient who has sepsis or pneumonia or aspiration pneumonia or any of the inflammatory issues that I mentioned, then you should be thinking, oh, this patient could be developing ARDS. What about if the patient's biting on the tube? Well, of course, if they're awake and biting on the tube, that is going to create a resistance to the flow of air going into the patient's lungs with or by the ventilator. So that's also going to cause the high pressure alarm to go off. Of course, you would talk to the patient and say, stop biting on the tube. If you're turning the patient and the endotracheal tube, which can be a little bit long, gets kinked, again, that's going to offer resistance to the flow of air. What if there's an obstruction? If you, the astute nurse or the respiratory therapy, have been slacking off and the patient hasn't been suctioned, even though they're making a lot of secretions, then those secretions can become an obstruction, and that will cause the high pressure alarm to go off. Now, the patient may be producing a lot of secretions, and so if you see this green looking snot or mucus bubbling up in your endotracheal tube, well, it's time to suction your patient. And so when you do that, then the high pressure alarm should stop sounding. The other thing is that the patient could cough. If you wiggle the tube, it's going to irritate the patient and they might cough. And if you cough right now, you notice that you're pushing air out. And so the patient, when they cough, will be pushing air out. And as air is trying to flow into the circuit, it means that air going out needs air coming in, and that creates an obstruction, and the high pressure alarm will go off. So again, whenever the high pressure alarm goes off, that means that there's some kind of obstruction or resistance to the flow of air being pushed into the patient's lungs by the ventilator. Well, if there's a high pressure alarm, there's a low pressure alarm. So if A high pressure alarm means there's more resistance. A low pressure alarm means there's less resistance. What would cause there to be less resistance in the circuit? Remember, this is all about within the circuit, within the ventilator circuit. Well, if there's a leak anywhere in the tubing, if it's disconnected at any one of the sites, then that means that the ventilator is blowing air into the room, and the room does not offer any resistance. Lungs offer always some kind of resistance, maybe not as much for some patients as other patients, but there's always some kind of resistance there. It's not butter. There's resistance in the lungs, even with the stretch. There can also be a leak if the endotracheal cuff is been deflated. In other words, some patients are very rough on the endotracheal tube, and I don't mean this intentionally rough. Perhaps it was an aggressive intubation the patient was fighting. Perhaps it was a crummy model or product, and the balloon just pops, kind of thing. The ventilator endotracheal cuff balloon pops. But regardless of the reason, if the endotracheal tube balloon is deflated, then there will be air that's blown in and it'll blow out the patient's mouth, and you'll hear it kind of going every time the ventilator pushes air in, it blows out. And so sometimes the alarm can go off for that too. Again, high pressure alarm, there's some kind of resistance. Low pressure alarm, there's some kind of leak within the system. Now, before every exam, Dr. Reed will do what's called either an exam review session, or she'll do Jeopardy. Sometimes on campus, she'll do that after every class. It doesn't matter, whenever she does it, Dr. Reed will do an exam review or Jeopardy session. It's real important that you look at it, because it's your tips and clues on what Dr. Reed is putting on the test. And I can give you some vague ones, but she'll give you more specific. So one of the things that Dr. Reed does in her Jeopardy is she will identify the manifestations of ARDS, or adult respiratory distress syndromes. Manifestations, fancy way of saying the signs and symptoms. So here they're listed here: progressive refractory hypoxemia, VQ mismatch, tachypnea, respiratory alkalosis, increased peak pressures, and altered level of consciousness, restlessness. So some of those terms you're like, I got that part, and then other of the terms you might be going, what? What does that mean? So let's go through each one because it's important. And when we talk about progressive refractory hypoxemia, what's that definition? Well, it's hypoxemia, patients having a low oxygenation blood level despite an increase in oxygen delivery. So in other words, if the FiO2 started, say, at 40%, and then you went up to 50%, or the physician prescribed an increase of 50% because the patient was still hypoxic, or had hypoxemia, well, then this would mean refractory. And so again, that's kind of a clue as to identifying that ARDS is the problem. If the patient also, of course, is getting an increase in PEEP and they're still not rising in their oxygen level, blood oxygen level, and that also is part of the refractory, because PEEP and the FiO2 together should increase the PaO2, or the oxygen saturation. Let's talk about this other one, VQ mismatch. This is the one that is confusing because on the very extensive notes, there's a lot of reasons for VQ mismatch, and I don't get all of them, and you don't have to either. Let's break it down into very simple terms. So what does that mean? Well, there are two parts to inhalation. This is a review from A&P, and you know that the first one is that we breathe in air, and that air goes in the lungs, and that's called ventilation. That's where the V comes in. So V is ventilation, bring in air. And then the next is perfusion, because it's no good to have air brought into the alveoli, or O2 brought into the alveoli, without blood flowing on by to pick up the O2 and to pick up and for the CO2 to be dropped off. So that's the Q. I don't know who came up with perfusion as Q, but they did, so we're dealt with it. So that's VQ mismatch. That's inhalation to perfusion. So when we talk about this, it's physics. It's all the physics things, and that part of physics is math. And there is a consistent amount of air that's inhaled and a constant amount of blood that cruises through the alveoli in the pulmonary artery system. And that's why there's a VQ ratio. So when we think about it, there's 4 liters of air that on average is inhaled and 5 liters of blood that's closing through. And when you divide 4 by 5, then you come up with 0.8. So in other words, every patient, every person should have a VQ of 0.8. That's normal. And if there is something abnormal, in other words, if the value is higher than 0.8 or lower than 0.8, there's something wrong. And physicians will do the fancy math physics equation because that's what will help them make the diagnosis for the patient. Is it a problem with blood flow in the lungs, or is it a problem with airflow into the lungs, and so on and so on. What you just need to know is that there is a VQ mismatch, and that's part of the diagnostic criteria for ARDS. Tachypnea, you know what that is, a rapid respiratory rate, which will lead to respiratory alkalosis. So when your patient comes into the hospital, and let's say they came in and they're having bariatric surgery, that's surgery. Slice and dice somebody, it's going to trigger inflammation. Trigger inflammation, you're going to have inflammatory mediators. Inflammatory mediators, you have the potential to have ARDS. And so when you have ARDS, again, I say inflammation, you say leaking, and that means that there's water that leaks into those alveoli, and a low oxygen state will occur initially. And as that oxygen state in the blood decreases and it moves around throughout the body, especially as it travels to the brain's going to go, yo, there's not a whole lot of oxygen in this blood, and I need oxygen. I can't work without it. I need more oxygen. And then the brain, the respiratory centers in the brain stem, will tell the lungs to breathe faster, because that's how the body works. The brain tells the lungs how fast and how deep to breathe. That's how we work. And when there is a low O2 state, then the brain will tell the lungs, well, you need to breathe faster and or deeper. And what does that do? Well, we know it doesn't help in ARDS with oxygenation, because the patho and the happening in the lungs is not allowing oxygenation to occur very well. But we do know with breathing deeply and fastly, we will definitely get rid of CO2. And that's why your patient, sign and symptom initially, that tells you, the nurse, that they're developing or may be developing a bad problem, is respiratory alkalosis, because that tells you, the nurse, because it tells the brain that there is a low O2 state in the body. So respiratory alkalosis, we kind of poo-poo it, and you learned in patho that it's all about anxiety. Well, it's not. Respiratory alkalosis can indicate the impending crisis of a very sick patient. So be on the lookout for it, that when your CO2 is low and your pH is high in an alkalotic state, you better look at the oxygenation status of your patient, because it could mean they're in trouble. Altered level of consciousness, restlessness. Now, this is a big one, because low oxygen states and even high CO2 states will cause a patient to go wackadoodle, because we know that the brain needs O2. And it doesn't like a high CO2 state either. That's not part of ARDS. ARDS is all about O2, but I'm going to throw it both in there right now. But altered level of consciousness is a sign that there can be a respiratory problem, that the oxygen state is low, as you would see in impending ARDS. Increased peak pressures. All right, now we go into some more details. So as I've already mentioned, when the patient's first placed on a ventilator, the respiratory therapist assesses how much pressure or force it takes. And the ventilator actually measures that effort that the ventilator is doing, and that's known as the peak pressure. So if you go look at the peak pressure on all of these patients in the hospital that are on a ventilator, you'll see there's a number attached to it. And that number can be anywhere from 20 if the lungs are very stretchy to 40 if the lungs are not stretchy. You don't have to know these numbers. You don't have to know the details. You just need to know that your patient's pressure, or the amount of effort, stiffness of the lungs, can be measured on the ventilator in a number, in a numerical value. And again, if the peak pressure is set at whatever number. Let's just throw it out there and say 30. Let's say your patient's peak pressure norm is 30. Well, if it goes way over 30, then it means it's high, and that means there's something happening that's causing them to be even stiffer. So we've already talked about the patient whose high pressure alarm goes off, and what that means is that the peak pressure is going up. Why is it going up? Well, you have to determine that, because we've already talked about what are the things that cause the high pressure alarm to go off, and that's some kind of obstruction. Is it a stiffening of the lung? Is there a lot of snot and secretions in the airway, in the upper airways? Or is the patient biting or kinking the tube? So again, when it relates to ARDS, which is on exam 1, it's really all about assessment. It's about assessing and looking at the patient and the ventilator alarm that's going off and determining, what is this? Is there obstruction in the tube, in the patient's lungs, or is there a problem with increased resistance and decreased compliance, which would signal ARDS? Last topic, and that's the mixed venous oxygen. This is a topic that, in my mind, is slightly complex. There's only one question on it on exam 1. There's only one question on exam 2. 3, there's usually not any. The final may or may not be one. So if you're one of those students, that says, I can get rid of one question, I don't have to have it, and you're happy with that point system, then stop the recording and move on. If you're the inquiring mind that says, I want that point because I want an A in this course, well, then keep listening. All right, so we're talking about mixed venous oxygen. So in other words, you know that the oxygen level can be measured in the arterial blood, but it can also be measured in the venous blood. And we say mixed venous when it's on the right side because we have a lot of things just zipping back. I didn't draw all of them, but when you look at this and you see this blue heart is meant to represent the right side of the heart. That's the venous side, the right heart. Yes, I realize that the right and left are attached, but we, for the purposes of learning, divide them out. So you see that the blue heart will have blood coming down from the head, venous blood coming down from the head, and venous blood coming up from the legs, from the feet, and from everywhere else. And so that is where we will draw, from a central venous catheter, we will draw oxygen or blood, and we'll measure the mixed venous O2. So SVO2 is the abbreviation for mixed venous oxygen saturation. Notice that normal is 75 to 80%. Now let's go over here. And we see that arterial oxygenation can be anywhere from 80 to 100. PaO2, excuse me, we're doing saturation, so oxygen saturation should be 90 to 100. 95 to 100 if you're a J1, J2 or taking an ATI NCLEX course. So we know that the right side of the heart is oxygenated blood, and so let's say that it's around the 100% range. Now what I do is I liken the right heart, left heart to a UPS truck. So if you think about starting out the UPS truck, if we think about the UPS truck that starts here in the left heart, it's docked in the left side of the heart, and it's picked up a lot of blood with oxygen. So think about the oxygen as little O2 packages. And so the truck picks up all of these O2 packages, and it makes its way around the body. And as all UPS trucks, they drop off the little O2 packages in all of the cells, all the way down to the feet. And so we see that O2 delivery is done by our UPS truck as it makes its way around to all of the cells dropping off O2. And then the UPS truck says it's time to head back to home base, and it goes back to the right side of the heart. And so by the time it goes off to the right side of the heart, if it had started out with 100 packages, it should actually have 75 to 80 packages left in the truck by the time it makes its way back to the right heart. Wow, that doesn't seem like much. And if you're thinking that, you're exactly right. The body is so efficient, or I should say the cells of the body are so efficient, they only extract or take out anywhere from 25 to 20% of the oxygen that is moving around in the blood with each pass. So it's not a lot on a good day. So let's talk about a bad day. What would cause the venous oxygenation saturation to go way down? In other words, what would cause this UPS truck to drop off a whole lot more oxygen than normal? Instead of dropping off 20 to 25 packages, what would make the UPS truck drop off 30, 40, 50 packages of oxygen instead of the normal 20 to 25? And these are the things noted over here, that would cause more drop off. In other words, these are the things that cause the cell to use more oxygen. Well, it makes sense that when the cell is very busy fighting infection, or when there's a fever, that more O2 is going to be needed. Pain, stress, lack of sleep can also cause the cell to demand and need more oxygen. Now, this one is a little bit of a stretch, and again, it's something you'll never be tested about. But if there is a reduced cardiac output, then that will also increase the cell's extraction. So what do I mean by that? What if instead of a UPS truck stopping on by that cell every minute, a UPS truck was only dropping off oxygen every hour because there's a lower cardiac output? Well, the cells are not stupid. The cells are going, yo, you're not coming by very often, blood, or truck. I'm thinking I better take more while you're here. And so the cells will do that. They're that smart and that adaptive to a lower cardiac output. So these are the reasons why this SVO2, the mixed venous oxygen saturation, would be 50, 60, 70 range instead of the normal 75 to 80. Now, will the opposite occur? And yes, it can. Sometimes in certain issues like sepsis, the UPS truck is filled with oxygen packages, but the cells can't grab it or can't extract it. And so if it's 100% here, by the time it makes its way all the way around, maybe 1 or 2 O2 packages have been dropped off, and the mixed venous O2 is 90. And that's a bad, bad sign, because your cells have to have oxygen or they're not doing well. Contact me if this doesn't make sense or you need further explanation. I hope this recording has been helpful.